Good morning, everyone. I'm Lindsay Goldfarb, Director of Healthcare Education at the Massachusetts Health and Hospital Association. And on behalf of MHA, welcome to today's Executive Insights webinar. MHA is so excited to continue this series into 2022, which features candid interviews of the leaders who power our hospitals and health systems. Today's theme is the Baystate Standard. A few logistics before we begin. We'll be recording this session for those who aren't able to join us, and all lines will be in listen-only mode. If you have any questions during the webinar, please feel free to enter them into the chat box. The questions will come directly to us, and we'll do our best to address as many as we can during our time today. Following the webinar, we'll be sending out the webinar recording along with a brief survey. I'd like to take a moment to thank MHA's 2022 sponsors for their support in underwriting today's educational program. In particular, I'd like to thank today's program sponsor, e-Ink. A valued supporter of MHA, e-Ink is a pioneer in e-paper technology and digital displays. Now I'll hand it over to Tim O'Malley, AVP for the Regional Business Unit from e-Ink, to say a few words. Tim, over to you.
Great, thank you, Lindsay. e-Ink is honored to sponsor this session of the Executive Insight Series. e-Ink is a technology company actually founded in Massachusetts out of the Media Lab that has pioneered the use and invention of digital paper. We're passionate about improving the availability of information with healthy and sustainable digital paper products. You may know us from our work with the Amazon Kindle, from signs around town, such as in Government Center and in Kendall Square, or from the Invented Here plaque in Logan Airport Terminal C. We aim to bring our digital paper to hospitals and healthcare via digital whiteboards, door signs, and e-note solutions. As an example, the digital whiteboard marries the appearance of a traditional whiteboard with the accuracy and labor savings of connecting it to your EMR. It can be a whiteboard that is always up to date, easily translated to any target language, and doesn't need to be erased when you leave the room. Look at the paper discussing our clinical trial with the digital whiteboard from Brigham and Women's Hospital. We have a pilot program and we're very anxious to work with Massachusetts hospitals, so please reach out. Our contact information will be shown at the end. It's my pleasure to turn it over to your moderator now, Steve Walsh, President and CEO of MHA. Steve.
Thank you, Lindsay, and certainly thank you, Tim. It's great to have e-Ink joining us again. And to all of you, Happy New Year. Hopefully the days will get a little happier as we continue to move on. As you know, we're in tough times right now, but I think it's all the more important that we have this conversation today with Dr. Keroack. Thanks for joining another episode of our Executive Insights series. I know many of you joined us last year, and so here we are again in 2022 to bring you more great conversations with the leaders of our healthcare system throughout the Commonwealth. Also, and again, acknowledge how difficult this has been for all of your teams. There's no longer a doubt that this is, in fact, the most pressure that our healthcare system has ever been under. So thank you for your ongoing leadership, for your resilience, and your commitment to the patients and communities that you serve. With that, it's my pleasure to introduce today's guest, who has been at the very center of our state's response. Dr. Mark Keroack is the President and CEO of Baystate Health, a longtime member of the MHA Board of Trustees, and a critical voice for public health, both throughout the Commonwealth and particularly and acutely in Western Massachusetts. Dr. Keroack provides strategic, financial, and operational oversight for all services at Baystate Health and its subsidiary health plan, Health New England. Baystate Health includes over 600 providers at 75 practices across the region. He came to Baystate Health from University Health System Consortium in Oak Brook, Illinois, where he served as Senior Vice President and Chief Medical Officer. Dr. Keroack has also served on the faculty of the University of Massachusetts for 12 years. During that time, he has focused on HIV and AIDS care and has won 5 annual teaching awards. Dr. Keroack is a graduate of Amherst College, Harvard Medical School, and received his MPH from Boston University. He trained in internal medicine and infectious diseases at the Brigham and Women's Hospital in Boston. Dr. Keroack, thanks for your ongoing leadership, and thank you for joining us this morning.
Thank you for having me, Steve. It's great to be with you.
You know, and we usually start this by talking about your career, and we'll get to a little of that because I want to hear how you got to where you are today, and I know our viewers do. but we can't begin without acknowledging the pressures that you and your staff are under right now, given that we are in the midst of this ongoing crisis. Can you give us a sense of where things stand and what will be needed for us to make it through the next few weeks?
Yes, it's been a really tough few weeks at Baystate Health with this new contagious Omicron variant. A couple of days ago, we hit our all-time high inpatient case number across our 4 hospitals of 325. Previous peaks had been only 180 or so. About 35 of them are in the intensive care unit, and just about all of our hospitals have been operating at 5 to 10% over their licensed bed capacity. This incredible demand comes at the same time that we have critical staffing shortages. Since the beginning of the pandemic, we have had multiple early retirements and resignations. Our workforce of nearly 13,000 had 1,800 vacancies before Omicron. And as of yesterday, we had 880 people out on COVID protocols, 700 confirmed positive. So roughly 20% of the workforce is absent as well, putting just additional strain on the people left behind. We're bringing in about 100 people a week and have a number of folks on contract, but it's been a scramble each and every day to manage the demand with an exhausted and diminished staff.
Yeah, thanks. I, as you know, I had an opportunity to see you in your flagship hospital the other day, and what a remarkable operation you and your team are running. I mean, you're using every square inch available to you and treating patients to the best of your ability and still taking care of the community. So thanks for that. I know we're gonna come back to that, but I do I want to do the from there to here. Can you walk us a little bit just through your healthcare journey? What drew you to medicine, and how did you end up on track to be an administrator?
Yeah, it's a sort of windy road, but let me quickly summarize it for you. My dad was an old-fashioned general practitioner. He had an office right in our house in East Springfield. Literally, you could open the door, the wrong door in the house, and wind up in the waiting room. So he was a solo practitioner, and he was the only doctor in the 16 acres neighborhood. So he was the doctor to all my friends. My mom also was a nurse who trained at the Springfield Hospital. So the influence of medicine was unbelievably strong in our house, to the point where all 5 Keroack brothers became doctors. I myself went into infectious disease because I thought that was the way to be Sherlock Holmes or Dr. House or something like that. But got the surprise of having the HIV/AIDS pandemic be front and center as soon as I came out of training. And so I was a busy HIV/AIDS doctor for 20 years, but also, of course, as an infectious disease doctor, it's about 25% administrative, infection control, antibiotic stewardship. And from that went into quality and safety when that crept onto the scene in the early 1990s. And then when the leadership of the system merged with UMass to form UMass Memorial, they decided that because I worked with doctors, I might be a good person to head the brand new medical group, which I started. Then after 10 years in Chicago, where I was traveling around visiting academic medical centers across the country, working in quality and safety, I came back to my hometown of Springfield in 2011, first to run the medical group, and then became the CEO in 2014. So not much of it was planned, unfortunately.
And so I've always find fascinating when we talk about some of the challenges of COVID with you, particularly because of your expertise. So as an infectious disease expert, how did that help inform your initial response, and how have you used that training and those skills throughout the pandemic to help all of us really to be able to see what was coming around the corner?
Yeah, well, my research as a fellow was in the genetics of RNA virus transmission. So it's kind of ironic that that has been a front and center issue, particularly now with Omicron. But as I mentioned before, I spent 20 years as a foot soldier in the war on AIDS, and that pandemic has taken 35 million lives over the last 40 years. There's some important similarities and differences. I think the whole idea of dealing with an unknown assault on our system and learning things on the fly and adapting on the fly looks very familiar to me. What is very different with HIV was that only a minority of the population was affected, and they were kind of social outcasts at the time. This, of course, involves everybody, and everybody's focused on it. I think what really helped Baystate was that we had an eager young infectious disease doctor who got us interested in Ebola back in 2014. So we had a team of people focused on emerging pathogens, and they started ringing the alarm bells on COVID back in early January. So we were ready a little bit before most people. And I also had a guy right out of Central Casting, somebody who our chief physician trained at Walter Reed in biodefense and vaccine deployment and was a major in the Army. So he was our incident commander, hands down. My own background, though, I think allowed me to focus more on the outside world and public health education, which was a big part of this whole response.
Well, certainly, I think it helped all of us as we were getting together regularly as CEOs in a hospital community. Your expertise was instrumental in helping us understand what was happening. So thank you for that. Shifting just to Baystate for a minute, our title today is the Baystate Standard. You have held yourself and your community and your system to the highest of standards. In the time since you've come, can you just talk about some of the areas that you are most proud of, and then maybe some areas that you look to improve upon in the future?
Sure. Well, my own training beyond the MD degree was a master's in public health. And so I bring the public health lens to things. And the reason I came back to Baystate was that I thought they really could make an impact on with mass health reform and population health. As we all know, the US health system is incredibly fragmented, multiple different payers, different reimbursement based on who's paying the bill or what diagnosis you have, which is kind of crazy. And so I think mass health reform, which you, Steve, had a huge hand in, forced us to refocus on population health under a global budget. And that emphasizes prevention and wellness. We as a system, rather than simply tolerating this, we made a strategic decision to jump in with both feet. And so right now, a typical Baystate primary care doctor has got 90% of his or her patients in an ACO arrangement and on a global budget. And that's meant we've had to really work hard to be a real system rather than just a collection of silos. First, by integrating all of our back office functions, and more importantly, integrating our clinical functions. So our 4 hospitals have a single hospital medicine group where people can move around, a single radiology group, a single pathology, single ED group. And so we're more systemy, I know that's not a word, than most of the other systems that you might encounter. We still, though, have some work to do. I think we're still learning the ropes when it comes to the social determinants of health through our Medicaid ACO. But I'm a firm believer that if we as a state continue to push the ACO model, it's going to incent all the right things in terms of health of our populations, health of our communities.
So just to follow up, so ACOs, accountable care organizations, for those out there that may not know that acronym. So what is is that the promise of the future? Do you think, are they going to work, and how does an ACO help a patient?
Well, I think it causes you to focus on the right things. You're doing things for patients rather than to patients. Probably the best example would be our Medicaid ACO, where we've got 45,000 people and all of them are insured by Health New England. These are some of the poorest residents of Greater Springfield. And rather than just sit there waiting for patients to come in and billing them for visits, we've hired non-degreed individuals from the neighborhoods as community health workers to go door to door and find out about housing insecurity, food insecurity, behavioral health issues, transportation, legal issues, all of these things that can affect your overall well-being and how well you interact with the health system. I think unless you attend to those things, you're not going to make headway in terms of overall health. You may get to see the patient who's sick again and again and again, but unless you figure out these social issues, you're not going to really get them to health, which is really our mission at Baystate.
Thanks for that follow-up. Certainly, I think there's an opportunity to be able to do important public health work while also taking care of our patients and making our systems healthier.
And-
I want to, so
And
sorry.
if I could, public health, I think, is something different from population health too. We've been very involved in public health during the pandemic, which is getting healthcare out to people who aren't even our patients. So when we stand up a free testing clinic or a vaccine clinic or public health education, we really don't care if you're a Baystate patient or not. We're really trying to direct ourselves to everybody in the communities we're serving. And that's even a step beyond population health.
Yeah, thanks for that follow-up. And that's really important work, right? Because if the community is healthy, obviously your patients will be faring better as well. Let's shift from patients to staff for a minute. And I know that's something that you think about regularly, and members of your team. You were our board chair. We spent a lot of time together during the nurse staffing ballot question. I would maybe argue that part of you bringing together the healthcare community to try to improve our system and come up with different and better ideas for the system than that ballot question is what led us to being so collaborative now when we needed it most in terms of COVID. I think you set the stage for that. But one thing that I've heard you talk about, I know is important to you, what came out of that was a caring for the caregiver task force. And can you talk a little bit about that work? And I know it's important now, but even before COVID, what you were doing to try to take care of our caregivers?
Yeah, well, the question one campaign was a real wild ride. I felt like I was a political intern learning from an old pro like you, Steve, in terms of how to assemble a coalition of people. So rather than arguing your point, you've got a posse of individuals that are working with you. So after that really huge come from behind victory, I was very proud as the chair of the MHA board to hear the board members saying, we really ought not to be whooping it up here. We ought to take this as a warning sign that there's distress among our workforce, and we need to do something about it. And so MHA really stepped up. Sam Melnick, Pat Noga pulled together a multidisciplinary group from people over all different parts of healthcare, including organized labor, the government, payers, et cetera. And I got to co-chair that with Donna Glynn from Regis College. And what we did was to divvy up the whole workforce issue into 4 key areas: workplace safety, worker engagement, workplace wellness, and then pipeline programs and deployment of staff. And for each of those, we tried to get the best and brightest minds from across the state to put forward what they thought were the key elements of excellence in each area, as well as some real practical best practice examples. So we had all kinds of robust discussions and arguments as this group, which was kind of fun over about 9 months or so. And then we came up with a great report, which I think really serves as a roadmap for somebody who wants to make their organization a workplace of choice.
And so that early work is critically important. And at the time, right, I think you, Donna, Sam, Pat, and the great members of the team that worked on it could have never anticipated what caregivers would be facing now. It's even more magnified than it ever was. Are you finding some effective ways to try to protect, help, care for your caregivers and your team now? Is there anything that you have learned and that we can learn from you in that area?
Well, I'll tell you, the first thing we did after that first wave, when there was a lull in the summer of 2020, we took a look at our strategic plan, which we had just minted before the pandemic, and said, look, workplace of choice has got to be our number one strategy, because I had spent so much of my time trying to keep people healthy and protected during that first wave. Remember all the fights about PPE and testing, that it really dawned on me that my main job as the CEO was to take care of the people who then would be taking care of the patients. It sounds, obvious, but there is a temptation for people to jump right on there and think about the patient and bypass the worker. So we've prioritized that. And I told you the hole that we're in as far as staffing. We are continuing to make investments in safety, both to protect folks from infection, but also from workplace violence, and also the mental distress that comes from being asked to do too much. Those are all things that I think are issues of safety. There's issues of engagement, which require, respecting the individual nature of the unique individuality of each patient. That then leads you to really making substantial progress with diversity, equity, and inclusion and institutional racism. We've got some interesting policy revamping going on and some hiring guidelines there. In the wellness side, it's acknowledging people, emotional support, acknowledging that they've been through a traumatic event and it's going to take a while to recover and that it's okay to ask for help. We've got 19 people manning our employee hotline now because there's so many people concerned about have I been exposed, what do I do, et cetera. I think as healthcare workers, we are really good at committing to the work, but we're not so good at unplugging and refreshing. So I think all of these things come together in a set of stuff that I've heard people call it psychological PPE, which is a term I like, which is a really good way of thinking about how to take care of the workforce.
I know the other thing you've been thinking about a lot, you're co-chair of the Massachusetts Healthcare Collaborative, is the pipeline. Right? I mean, as a lot of the members of our teams have attrited post-COVID, do you see a strong pipeline? Are there other things that we should be doing to get people into this great profession?
Yeah, we part and parcel of this, question. One thing I was asked to co-chair something with the Secretary of Labor and Workforce Development on how do we build those pipelines, and some of the pipelines are struggling. We don't have enough nursing faculty to provide us, even though we have a nursing shortage and people waiting to get into nursing schools. There aren't enough faculty or clinical placements for that pipeline to be broadened and enhanced. For people who are direct caregivers, there are issues of a cumbersome certification exam and being supported during the studying process. For behavioral health workers, there's issues of advancement and what does it mean to move into a career? Is it a dead-end job to be a behavioral health worker? So each of these areas has a specific, almost signature and a set of challenges.
Just want to remind folks, if you have any questions, feel free to put them in chat. We'll try to get to them as we come to the close of our time together. I've talked to several leaders of large systems, but most of them are based in Boston. And can you just talk a little bit about what it means to be in the greater Springfield market and some of the unique challenges that you face as a leader in that region, and also maybe if that provides you any opportunities?
Yeah, well, first of all, I'd say it's beautiful out here. People ought to come visit. It was a toasty 6 degrees when I got up this morning. You'd like it out here. But joking aside, we've got about a third of the land in the Commonwealth in Western Mass, but only 1/8 of the people. So things are, I've got a very comfortable 20-minute commute every day. And we have an amazing mix of different kinds of patients. We have cities with high rates of poverty and unemployment. We've got college towns with very demanding, well-educated consumers, and some rural areas with challenges like transportation and broadband access that have been hit hard by opioids. And so the social determinants of health show up in very different ways across our territory. And we try to do it all under one roof. Baystate Health is the only tertiary care center in all the 4 counties of Western Mass. We're the only level 1 trauma center, only level 3 NICU, only cardiac surgery center, specialty cancer, high-risk OB, children's hospital. The list goes on and on. So if somebody has a serious problem anywhere in the 4 counties requiring tertiary care, they're going to be brought to Baystate. So in addition to being a tertiary care center, we're the leading safety net provider. We do 3 times as much Medicaid as the second largest provider in our area. And so it makes for a kind of an interesting mix doing this all under one roof rather than having 3 or 4 different academic medical centers in the same town as you guys have in Boston.
Yeah, it's certainly it's a big roof. I mean, you got a lot going on in that building. It's a really remarkable operation for anybody that hasn't seen it. I mean, you really are doing everything and doing it at the top of your game. Just back to you for a minute. And you talk, and I know, and you've talked to me about it. You've talked to others. I've heard you mentor people about taking care of yourself, caring for caregivers, taking care of your own needs so you can be your best. where do you draw your inspiration from? I mean, this has been a tough time for you as much as anybody else. What do you do to get your mind off some of the challenges to be able to recharge every once in a while?
Yeah, well, I'm kind of a history buff, so I'm a big reader, particularly of American history and some of the forgotten periods, like the 1820s or the 1880s, and I love reading about the nooks and crannies of American history. And when I'm facing a tough time, I often look for historical examples to guide me. I'll give you the example with Omicron. When I saw this tsunami of cases coming and people just getting crushed, and feeling totally helpless to get additional people brought into the fight because of our staffing shortages, I actually picked up my biography of George Washington and read about him at Valley Forge. And I said, this is our Valley Forge. When Washington couldn't do anything to help his poor soldiers who were freezing and starving, what did he do? I wanted to know that. Well, turns out he rounded, he walked around. He basically visited people. He acknowledged the suffering they were going through, told them how important the work was, and really just sympathized with them, while at the same time fighting to get resources for them. But that really kind of, I think, helped me to understand what I needed to do. So I just doubled down on my usual rounding schedule, and I found it very encouraging to see how upbeat people were in spite of all they were doing.
Yeah, I think that's an interesting point. I know you have said that to some of our other CEOs. You're having a bad day, just get out of the office, stretch your legs, talk to people, see what's going on the ground, and inevitably it will give you a little bit of a lift because of all the incredible work that's happening. I had a question come in about I found interesting, I hadn't asked you this too, but I've been intrigued. Is anyone else out there paying attention to some of this psychological PPE or pay incentive retention? Have you found anybody willing to reimburse for those type of services for staff?
I think it's something that you have to invest in. You're going to pay for it one way or the other. If you have high turnover, you're going to be ending up paying roughly twice a yearly salary to sort of make up for the turnover. And so we've put in place a variety of bonus programs. I think we spent over 40 million in bonuses in fiscal 2021, in addition to 40 million in contract labor. So you're going to be spending it one way or the other. So so you need to just kind of swallow that. There are some monies in the American Recovery Plan for workforce development, but that's more about building those pipeline programs.
A question about your facility, and I know you've been so creative. I saw you set up a site on an old parking lot. But the question is, how have you been handling the physical limitations, facility challenges, space transformation, clean air demands for the current needs?
Our facilities people have been amazingly creative. Steve saw that we have a bunch, like many New England hospitals, we have buildings that date from the 1930s all the way up to 2012. And there are nooks and crannies that people, we stood up a 12-bed pediatric psych unit with some fast capital from the state in, the top floor of that building from the 1930s. And midway through, we found out we literally had bats in the belfry. And we had to like pause the construction and get rid of the damn bats. And then, got the HEPA filtered air and all that stuff in there, and actually have 5 PD psych beds for COVID positive patients. So yeah, I'm just a poor country doctor. I don't understand a lot of this facility stuff, but these guys are real magicians.
Well, when you walk around, it's clear that you and your team understand it. We had a question about the Workplace of Choice report. I'll talk to you if that ends up being available. I will send it out to those that joined us today as we're coming up on time. I like to close and give you the last question on. We have a lot of emerging leaders that watch these and learning from our incredible CEOs. What advice do you have for some of the emerging leaders in healthcare, or really any other sector for that matter?
Well, first, to thank them for stepping up. We need young, energetic leaders. I firmly believe that leadership is a set of learned behaviors. It's not some genetic gift. Leaders are made, not born. And I did a lot of work when I was out in Chicago, getting a coalition of chief medical officers to develop leadership curricula for physicians interested in leadership. We've done something similar at Baystate called the Physician Leadership Academy, and we've had 110 young physicians go through who are interested in getting those skills. One of the things, 'cause I do the opening lecture in that, and I always define leadership as an act of social influence to channel the energy of a group of people toward a common purpose. You don't have to have authority. You don't have to have a particular personality. You need to have some clarity about what you're trying to do, some clarity of purpose, and you need to understand something about yourself, how you successfully influence people. A lot of folks think you have to be like Winston Churchill or George Patton to be a good leader. But you can, if you understand how you affect other people, you can do it in very different ways. Think of Rosa Parks, who had a quiet act of resistance, had no authority, but galvanized the energy of an entire city to move in a positive direction. So the key is really understanding how you manage to influence people and also having some clarity about where you want to go once you get that energy from those around you.
That seems like a great place to wrap up. These quick conversations fly by. I know we could have done this for another hour, but yeah, I want to thank you for joining us. Your leadership in Western Massachusetts and for the entire MHA community continues to be simply invaluable. We are certainly lucky to have you and your expertise on our side. We're looking forward to staying closely connected in what promises to be a difficult start to this new year. And we wish you and your team all the best in the days ahead. Thank you again to E Inc. and all of our sponsors, and to you, our attendees, for being part of today's Executive Insight series. MHA offers great programming on a weekly basis. We encourage you to visit our website for more information on what we have in store. And we also encourage you to register for MHA's upcoming Joint Commission Update Conference tomorrow, January 13th. Thanks again for spending your morning with us. We look forward to seeing you at the next Executive Insight series. Thank you.